from the American Academy of Pediatrics.
Charting after patient visits takes a lot of time, even with the help of the electronic health record.
How can the EHRs we use better deliver the pediatric functions we need?
You want to be able to visualize their growth. You want to see their current developmental status. You don't want to have any trouble dosing a medication safely.
Plus, research on animated movies shows a need to change the way we look at crossed eyes or strabismus.
It looked like it was something that they were intentionally doing to try to communicate to the audience that a character was stupid or a character was a bad guy, that it was not a desirable character or a character worthy of admiration.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Balinki. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode with a conversation about pediatric functions within the electronic health record.
Joanna, I was almost late for this podcast because I had to finish up some charting from my hospital shift. Sometimes it just feels like the charting systems we use are not really made for kids.
I don't think they are, David. I know in my neonatology practice, we always are trying to modify order sets and charting to reflect the very specific treatment we like to give in the NICU, rounding all our medications to the 100th of a kilogram.
Ooh, I know how specific NICU care can be, and I don't think we've ever said this on the podcast before because our listeners already know, kids are not little adults. I just want to say that to some of the makers of these EHRs.
Well, if you don't have a direct line to them, I think our next guest might. He's one of the authors of a clinical report on special requirements of electronic health record systems in pediatrics, Dr. Andy Spooner.
Dr. Spooner is a professor of pediatrics at the University of Cincinnati and chief medical information officer at Cincinnati Children's Hospital. He's focused his technological work on making sure that health systems are considering the unique needs of children. Andy, welcome to the show.
Hi, how's it going?
We know that the electronic health records are not always made with children in mind, and because of that, your report mentions pediatric functions. What are those?
Yeah, this report talks about what we call pediatric functions, but the truth is there's really no function that's exclusively pediatric, with the exception of growth charts, maybe. I mean, you don't find growth charts in adult health records. But, adult providers provide immunizations, they do assessments, that sort of thing. But there are certain things that are so much more important in pediatrics that we regard those as pediatric functions, like tracking growth, tracking development, tracking immunizations in that detailed way that pediatricians just love. How to dose medications by body weight, whether it's an oral dose of antibiotic or a bedside patient-controlled analgesia device. There's all sorts of complex weight-based dosing that we need to deal with.
So, Andy, over the course of my career, I've probably used 6 or 7 EHRs, and that goes way back. What's the state of the industry at this point? Are we consolidated into a big 3, or are we still kind of all over the place?
Well, it kind of depends on what sort of institution you work for. I mean, certainly among children's hospitals, there's a tremendous consolidation of vendors, and there's basically 4 vendors of a certain size that service that sector. But once you start getting smaller scale, it fragments into a much broader market of all kinds of different companies of various sizes that are operating in this sector. Meaningful Use really boosted a lot of these vendors because they were able to get customers who had money to buy their product. And so there was a lot of growth in some areas of this industry. But when you go out to the workaday community pediatric practice, you see an incredible variety. We do not all use the same EHR. We could not all possibly afford the same EHR. A lot of these systems are based on what people can afford in their practice, which, pediatrics is not a high margin specialty by any means. And so we're dealing with a lot of smaller vendors who are doing the best they can to provide a product that's responsive to their customers. When I have a problem with my EMR, I get on the phone with my vendor and have all these conversations, and they send analysts, and people get on planes and they fly around and have meetings. That doesn't happen in real life in a smaller practice. You buy the software, you turn it on. Maybe there's a period of configuration a little bit, and then you're flying. I mean, there's not any of these meetings and customizations and all that kind of stuff. You got what you got. So it's still very heterogeneous.
Let's get into some of the functionality of these EHRs. It would be nice if EHRs helped make the day-to-day care pediatricians provide more streamlined in terms of when to give immunizations, for example. What should pediatricians expect their EHR to know?
You want your electronic health record to help you with some of these time-consuming tasks, like assessing whether they're up to date on their immunizations. That shouldn't take you 30 seconds to sort that out. That should be an instant read from your EHR. Knowing where they stand on their growth, knowing where they stand in their development, knowing how to write an accurate prescription for their weight. All of those things your electronic health record should allow you to do without slowing you down at all.
And every day in the NICU, we're plotting the weight of our babies. We like to use different growth curves than the CDC or WHO ones, sometimes opting for things like the Fenton growth curve. Would it be expecting too much for all EHRs to offer these more nuanced curves?
Well, that's one of the major things we do as child health providers, of course, is track growth and development, which means that we need good supportive growth curves that respond to certain contexts. The basic functionality we need is the good World Health Organization and CDC growth curves, of course. You can add lots and lots of other functions to that, like correcting for gestational age, providing different norms, like Fenton, for instance, you mentioned, is the most popular preemie growth curve set of norms. There are many, many other published norms for growth that have many different applications. I think a vendor could be forgiven for not supporting the Kabuki syndrome growth curve, which exists, but they certainly should be able to handle the major ones that we've just mentioned for sure.
And what about developmental milestones? Because I know the CDC just updated those.
How one assesses development, there's lots of discussion about that. Should it be milestone-based? Should it be based on different other kinds of assessments, that sort of thing? Whatever method you use, you need to be able to track it. So you can deploy any number of assessments in your electronic health record, of which there's no shortage, of course. One of the bigger problems in this area, of course, is intellectual property. So when someone publishes a metric, they, at least years ago, they didn't necessarily expect that it be implemented in an EHR, but people went ahead and implemented it. And then the publishers would say, hold on a second, we didn't really license it that way. So that got sticky for a bit. But now we have some open source methods of tracking development, for instance, and that is certainly popular and appropriate for use. But it's not so much supporting the metric, it's tracking it, which I think is the most critical function in an electronic health record, because you've got to be able to sustain that assessment throughout the lifespan. And if they failed a developmental screen, 6 months ago, and it's hard to get to, or hard to appreciate where they are in their developmental schedule, then that's not really doing you much good, is it?
I remember in the past when someone needed amoxicillin for an ear infection, I'd just scribble out a script, tear it off, hand it to them. At this point, I could not even find a prescription pad. So should I be trusting an EHR to write all of my prescriptions for me correctly?
Well, you certainly need tools within your EHR to create your favorite methods, or as much calculation is done ahead of time as you need to. Now, when I was early in practice, I carried a little card in my pocket, and I said, okay, what weight child needs a teaspoon of this? Mm-hmm. And so you could say, well, this kid weighs about 1.5 times that, so I'll give them 1.5 teaspoons. I mean, it was good enough for most sorts of things. And what I was looking for was reliable calculations. And of course, now we have weights that are taken into our systems. We have pretty good workflows for getting weights, and it can calculate those weights. Where I thought you were going, what do I need to do to prepare for when my EHR is not available and I don't have that prescription pad around? There is a tremendous amount of concern nowadays about failure of electronic health record systems. We recently had a failure of our system where the so-called CrowdStrike debacle, where we lost access to a lot of our PCs. We restored functionality within a few hours. But famously, a large children's hospital in the Midwest was down for more than a month. That I'm sure there was some discussion at NCE about that as well. And you got to go back to paper, and you have to be a pediatrician. You have to do what you need to do. So what do you do if you need to be a pediatrician, but you've never, ever used paper? I mean, for you and me, not such a big deal, but for folks who are younger, it can be a problem. And what happens when all of us oldsters actually do retire and no one remembers how to use paper? Well, okay, so that's a hard problem, but it's easy to tackle because you've got to rehearse, you've got to practice, you've got to prepare, you've got to have that stuff in a cabinet labeled, in case of emergency, break glass, and bring those forms out and start to do what you need to do. So you certainly shouldn't throw away your prescription pads completely.
That's good advice, to have an emergency stash of paper. But we do put a lot of data into the computer and into children's charts and teenagers' charts. How is all this data kept confidential, and what do these systems do to ensure only appropriate caregivers can have access to it?
Yeah, so keeping things confidential, of course, we've got rules about security, courtesy of HIPAA, and certainly all the vendors of electronic health systems take all that very seriously, as they should, except we're all vulnerable to hackers. Now, what are hackers after? Are hackers after a bunch of immunization records? No. They're after credit cards, they're after social security numbers, they're after, I suppose they might take some medical information and use it to, blackmail people or something. I don't know. I don't see that the bulk of our medical records are as much of a target as is the financial stuff that we have, which is also part of our electronic health record systems. Okay, I'm not trying to say that electronic health records are not a target. They certainly are. I think the main motivation for a lot of these cyber attacks is either the financial aspect, getting a hold of credit card numbers, or it's the ransomware issue where you say, okay, this is a little practice. Surely they would pay $10,000 to get restoration of their computers. So that's really the present threat that we have. And there's a big industry regarding cybersecurity to keep those things very secure and protected. The days of buying a PC at Best Buy and running a server under your desk in the back room, those days I hope are gone. I mean, I think if there anything like that you have, which was a very common sort of thing back in the late 90s, is no longer there, and people have to use serious security. But talk of hackers is all very exciting. But in the day-to-day practice, the more important thing, the thing that's going to come up more, is keeping information confidential as appropriate. And this arises mostly in adolescent care, although it's not exclusively confined to adolescent care. We believe as pediatricians that if adolescents know they can get some confidentiality from us, then they will be more likely to trust us with some of the more sensitive care that they have. I think most adolescents, I remember being an adolescent and I didn't really care about what happened to my healthcare information. But there are important situations where an adolescent would like to have some confidentiality. It doesn't have to be forever, but just a little confidentiality. How about some confidentiality this afternoon? Because I want to talk to you about this thing that's happened to me, and I don't want it to immediately show up on my mom's phone. I mean, oftentimes that's really enough. So you've got to have, when you set up your patient portal, you have to have some way to filter or segregate some of the information so that you can provide that confidentiality. And this actually is an area where, I know I'm working with my vendor very closely on establishing all of this, and I'm going to guess that in smaller vendors, this is a much bigger challenge because it's hard. It's very, very hard. Even for a big vendor to do this correctly is extremely hard.
The lives of children are so dynamic. Their identities and needs change over time. While technology does too, how do we make sure EHRs are one of those technologies that can support our children as they grow?
So one of the special things about pediatric electronic health record use is how long we got to keep the records. I mean, we've got to keep the records a long time. I mean, until the age of majority plus some number of years, depending on what some lawyer says. Okay, so at our place, we just say it's forever. We keep records forever. We do not throw anything away, and that's great. And it's one thing if it's a box of papers sitting in some repository in Utah, but it's very different when everything's online and everything gets exchanged. And what happens today in your pediatrician's office ends up in someone else's record somewhere else because of information exchange. Now, for most kids, it doesn't matter. But when you've got mental health issues going on, when you've got substance use disorder issues going on, when you've got issues of sexually transmitted disease, gender identity, any of that stuff, it becomes a lot more accessible to a lot more people, and it reverberates throughout all time now. So it's quite, it's actually kind of an unsolved problem as far as what to do when something comes back from your record from 10, 20 years ago. We don't know yet what that's going to look like, but that is a feature of pediatric record keeping that has got significant implications for what you decide to share. And getting back to our original point, I mean, you've got to think about, what am I sharing and with whom, and who has the right to see this information? Parents have the right to see their kids' records. HIPAA says so. But there's all sorts of asterisks on that particular requirement that require a lot of detail and a lot of settings in your EHR to make sure you get it right for what the adolescent usually is wanting.
And this is probably important for pediatricians to know when they're using an EHR, but are there laws or regulations that outline what capacities it should have?
There are no laws that say it has to do X, Y, Z. There are no laws right now that drive functionality. The big law nowadays, though, the big gorilla, if I can use that term, with all due respect to gorillas, is the 21st Century Cures Act. So we used to have all these conversations about open notes. Should we do open notes? Who should see open notes? Where should we start? And all that got swept away by the 21st Century Cures Act, which basically said people have a right to their record, which is always true, but they should be able to see it immediately upon request. And is a request to have a patient portal, does that constitute a request to see your records? Most people say yes. So on that basis, we provide lots of stuff, provide lots of access to information. Everybody was predicting, oh my gosh, when people start looking at their records, they're going to have so many questions. They're going to inundate us with calls. None of that's happened. I think people were always interested in their medical records to a certain extent. And I can just tell you that Open Notes was not a disaster. That's consistent with everybody's reports from around the industry. But it does represent a new way of thinking about, okay, what are we going to do? What are we going to record? Because the parents are going to immediately see this. The child is immediately going to see this. And maybe that's a good thing. I mean, we have nothing to hide, right? Except, of course, when there's a sensitive issue, then it becomes more of a problem. But in general, for most care, we don't really have anything to hide. But as far as to your original question about, is there someone who says the EHR should do this or should not do this? We don't have that anymore.
This may be an unpopular opinion, but I am still an enormous fan of EHRs, imperfect as they still are. So that I can go finish my charting, do you have any last takeaways on these necessary tools to help us care for our patients?
So one of the questions that I often think about is, why do people keep using EHRs? Now, on the adult side, it's an easy question to answer because they're going to lose Medicare money if they don't use the EHR. Okay, fine. But we're pediatricians. We don't really care so much about Medicare money. And yet we still continue to use EHRs. And the fact is, we want to keep good records. We want our patients to know what's going on. We want our colleagues to be able to cover for us when we're not there. So, there's lots of great reasons to have an electronic health record. But when it comes to finishing up your work and getting it done, thinking about all the things that you need to know, being able to accurately and quickly assess, are those immunizations up to date? I mean, if you're going to sit around and spend 30 seconds trying to figure that out, those 30 seconds add up across the course of a day. So you don't want to you want to be able to visualize their growth. You want to see their current developmental status. You don't want to have any trouble dosing a medication safely. And you want to be able to identify who the patient is, to whom to communicate, what the guardianship situation is, what the foster care situation. I mean, you don't want to be slowed down by any of that stuff. You want your system to handle that without a lot of sticky notes. Like you take a sticky note and say, remember, so-and-so is in foster care, so be careful. You don't, anything that requires you to put a sticky note on your monitor, you really don't want that. You want the system to help you. And so these functions that we talk about are really intended to encourage the development of helpful software for pediatricians. Yes, we still have, we still write too much in our notes. We still document too much data, really, honestly. We spend a lot of time doing this. There's no end of studies on the amount of time people spend doing this thing. We don't have a lot of studies about the time we spent before, though. I mean, it's kind of hard to compare, but it feels like we're spending more time on record keeping and documentation, right? And I accept that. I mean, I'm not going to sit around and try to say that back in the days of paper when, all you had to write for a well check is, feels fine. Those days are kind of over. Where people are expecting more from their doctors,
and no one could read it either because people expected doctors to have poor handwriting.
Oh, of course. I remember moonlighting for private practice when I was a young faculty person. I just come in on the weekends and and honestly, the well child documentation was exactly that. Doing good. Time for shots. It's like, okay, so we have a little bit higher standards. So medicine has changed. I mean, if you tried to come in with social determinants of health stuff 25 years ago, people would have said, stay in your lane, man. I mean, that's not for us to do anymore. But now it's an accepted part of our contract with kids is we want to care about these things, and we've got to have some kind of system to keep it all together because it's kind of hard to track, isn't it? So medicine's changed as well as the technology. It's not just an introduction of the computer. It's lots of other things that have happened.
Well, I think you just spoke truth to what so many pediatricians feel, juggling all of these things that are in the EHR. Dr. Andy Spooner, thank you so much for joining us today.
Thank you. Good luck with your neonates.
Thank you so much. To read the clinical report, Special Requirements of Electronic Health Record Systems in Pediatrics, go to aap.org/podcast.
Coming up, we'll look at depictions of strabismus in animation and why studios need to make a change. Some of us became pediatricians to nurture our inner child. And Joanna, I love animation. I grew up obsessed with cartoons, especially Looney Tunes, but also Super Friends, Speed Racer, even the short-lived Star Trek series. I carried that love into adulthood, and I never minded watching animated movies with my kids, at least the good ones. Unfortunately, Christy has never seen the charm.
Oh, I do, though. I am a big fan of animated cartoons and movies. I'm often watching them with my kids, and they can really pull on the heartstrings, like when a character dies or they have their hero moment. I'm all in.
And I love the visual language of cartoons, like the physics of the classic squash and stretch effect, the whole body expression of emotion, and the way a Trump rail tunnel can turn into a real tunnel for one character and then turns back into a cliff wall for the next.
I mean, we could probably talk about animation all day. But have you noticed now, on some Disney movies, there are warnings about the images? If you rewatch some old classics, racist and sexist stereotypes in films aimed at children were actually pretty common.
Yeah, now that you mention it, as an adult, I've given it a lot of thought. I actually didn't watch some movies all the way through with my kids, like Peter Pan, because of the depiction of Native Americans, gave me real pause, and I didn't want my kids internalizing that.
Our next guest has an eye for stigma and misrepresentation in animation. Dr. Michael Puente is an assistant professor of ophthalmology at the University of Colorado and Children's Hospital Colorado, and he is also an author on the new paper in Pediatrics, Depictions of Strabismus in Children's Animated Films. Michael, welcome to the show.
Thank you so much for having me.
Okay, Michael, this may be the only paper we've ever discussed that references animation. What was it about this subject that intrigued you enough to study it academically?
It was something that came to me all of a sudden when we were all locked up in COVID, streaming movies from home. I came across a new Pixar movie that was released directly to streaming. This is the movie Luca, which was about a teenage character from a family of sea monsters off the coast of Italy. And this teenage character, Luca, he realizes that anytime he goes up to the surface, he turns into a human, and he goes on all sorts of adventures as a human. But when his parents realize that he's been doing this, they're scared that he's going to be in danger if he goes up to the surface. And so they threaten him that if he ever goes up to the surface again, they're going to banish him to live with his crazy, creepy Uncle Ugo. And when Uncle Ugo is first depicted visually, when he first comes out of the shadows, you're immediately drawn to his eyes. He has an enormous exotropia, just a huge angle of strabismus, and his eyes at times are roaming around independently of each other. He's depicted as really creepy, a really undesirable character, and Luca's parents are saying that spending time with this character would be a punishment. It's a threat. That really got me thinking that strabismus was being used as a way to convey negative character traits. And I thought of some other movies I had watched in my childhood that had characters with strabismus. I really struggled to think of any positive depictions of characters with strabismus. So I felt like it would be important to look at it scientifically and see if this was a real thing.
And there are so many sources of animated material going back really to the beginning of film. So how did you choose the movies for your study?
So we knew that there are so many hundreds of animated movies out there, and it'd be impossible for us to watch all of them. No one has time for that. So we identified 4 studios: Walt Disney Animation Studios, Pixar, DreamWorks, and Studio Ghibli. They were the studios that had received the most nominations for the Academy Award for Best Animated Picture. So we felt like that was a way of identifying the top studios. And Disney has movies that go back to the 30s, the 40s. We didn't feel like it was going to be very relevant in the modern day to look at movies going back quite that far. So we started with The Little Mermaid, which came out in 1989, which was the first movie from a genre of Disney movies that are considered the Disney Renaissance, when you had movies like The Little Mermaid, Beauty and the Beast, Aladdin, The Lion King, that are really considered the gold standard of modern animation. So we looked at every animated movie released by those 4 studios since The Little Mermaid came out in 1989 up until the end of 2022, and it was 125 movies.
And were you the one person who watched all 125 movies represented in this work?
No, this was where the med students came in. I have a full-time clinic, beyond full-time. And so I found a team of five very eager medical students here at the University of Colorado who agreed to divvy up those movies. They each watched 25 of them, and they identified all the characters that had strabismus. And then we went back through as a team and did an analysis of all of those characters.
And in these movies, did you categorize characters by the ophthalmologic diagnoses that you would have made if they were real patients?
We did. So the medical students, they identified any character that they thought had strabismus. And then I went back and watched all the clips from those characters and verified as a pediatric ophthalmologist whether I thought the character looked like they had strabismus. And we categorized the patients into 4 groups based on their ophthalmic diagnosis. Either exotropia, where the eyes drift apart, like towards the ears; esotropia, where the eyes are crossing in towards the nose; hypertropia, where one eye is pointing higher than the other; or we also categorized some patients as having roving disconjugate movements, where each eye just kind of moved independently, variably. And the majority of patients had exotropia, or the eyes drifting apart.
And how were characters who didn't have controlled eye movements portrayed in these films?
They were portrayed very negatively. We found 46 characters with strabismus in these 125 movies. There were 33 movies that had characters with strabismus, and they were overwhelmingly portrayed negatively rather than positively. The characters with strabismus were 14 times as likely to be portrayed as unintelligent than intelligent. They were about 6 times as likely to be portrayed as followers rather than leaders. They were more likely to be villains than heroes. We struggled to find any positive representations in these movies.
So this may not have been in the study itself, but why do you think eye issues like strabismus end up being villainized or othered? Is it a reflection on beauty standards in our society or the language of film?
I think there are a lot of reasons for it. We're instinctively drawn to people's eyes. We like to make eye contact, look people in the eye. And so that's one of the most emotive parts of someone's body, I think. People say that the eyes are the window to the soul. And so if you want to portray someone as deviant, you want to portray someone as weird or othered, that's really the first place that I think people are drawn to. And it's the easiest way that you can immediately convey to the audience that something's off about this character.
And you have contact with tons of children who actually have strabismus. How do you interpret their impressions of these characters? Have you heard from any of them or talked about this?
I haven't heard from any kids specifically telling me that they were bothered by any of these representations, but I think it's just so ubiquitous for them that they feel stigmatized and othered because of this condition. Kids tell me all the time that they're being bullied in school, and that's one of the main reasons that parents want to get it fixed, not just for the visual ramifications, but primarily for the social and developmental ramifications. There have been studies that find that kids with strabismus are less likely to be invited to birthday parties. Teachers are more likely to think that kids with strabismus are less intelligent. Kids are less likely to share a toy with someone with strabismus. They're less willing to sit next to someone with strabismus in the cafeteria or in school. There have been lots of studies showing that this, just having strabismus, dramatically affects children's quality of life, ability to interact with society. And I suspect that these negative portrayals in movies are a factor in that.
And how would you like to see things change in the entertainment industry now that you've published this study?
I would love for animation studios to stop so consistently depicting characters with strabismus negatively. We really struggled to find any positive representation of characters with strabismus. It looked like it was something that they were intentionally doing to try to communicate to the audience that a character was stupid or a character was a bad guy, that it was not a desirable character or a character worthy of admiration. And I would love for them to just stop doing that so consistently. Maybe have some characters here and there with strabismus who are the good guys. Have some characters who are admirable. Have some characters who are leaders, who are intelligent. That's severely lacking in the movies that we reviewed in this study. I think it would do a lot of good for kids to have some role models in these movies with strabismus.
I suspect a lot of our listeners are going to want to read this paper for themselves, but before they do you have any last takeaways to share?
I would encourage readers and listeners to think of some of the animated movies they love and see if they can think of any characters with strabismus. And if they think of any, I bet they'll realize that that character is being portrayed negatively. This is something that's so pervasive in our society, probably not just in movies, but also in TV shows, in advertisements. I've noticed strabismus in some toys, in images on packaging. This is something that is a societal issue, the way that strabismus is being portrayed. And it's not fair to kids with strabismus or to adults with strabismus for it to be so consistently depicted negatively in our society.
Well, Dr. Michael Puente, thank you so much for doing this work and for taking the time to speak with us today.
Thank you so much for having me.
To read the article, Depictions of Strabismus in Children's Animated Films, go to aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
So Thanksgiving is coming, and that means that our far-flung children are all returning to the nest. And that means it's going to be absolutely nuts, but nuts in the best possible way. And I just treasure it more every year.
Oh, your family is so good about getting together, David. I love to hear these stories. And my Say is about a little bit of crazy as well. I chaperoned a field trip for my child's school, which does entail being really hands-on with a group of children from their class.
You are
brave. We had a great time. I was with my oldest daughter all day, which was wonderful. And then, she wanted to go to the park right after when we got back from school. So we went to the park and I left her backpack in the park, David. I just was so exhausted.
No.
And it's not like it has anything in it but her folder and her books for school. And then I didn't realize until the next morning, and I ran to the park, dropped her off, ran to the park, and the bag was there with everything in it, just sitting at the entrance to the park. And it made me just feel so good about my community and how supportive they are that a kid's backpack would still be there with everything inside.
That is to say, And that's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook, Instagram, and YouTube at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll look at safety in cheerleading.
We'll talk to Dr. Greg Canty about the transition from sideline support to challenging sport. I'm Dr. David Hill.
And I'm Dr. Joanna Pargavalinki. Thanks for listening.